This episode of the Senior Rehab Podcast is sponsored by the Academy of Geriatric Physical Therapy. AGPT's mission is to further your ability to provide best practice physical therapy and to advocate for optimal aging. One of their most popular articles published is Dale Avers' white paper on strength training for the older adult. You've likely heard us talk about this paper, but it is a fundamental piece of work that I highly encourage y'all to read. This paper covers proper dosage, how to set intensity, and how to get your patients strong. You can find this resource for free and much more over at geriatricspt.org/SRP. That's geriatricspt.org/SRP. Hit me.
This is a Senior Rehab Podcast, the podcast for rehab clinicians that want to better serve older adults.
Hey there, Senior Rehab Podcast listeners. This is Erin Carey.
And I'm Tali Spaceman.
And you are listening to SR Prereqs.
What do you have to teach me today, Erin?
This is an article that I got from the Academy of Geriatric PT newsletter from April. It is an open source article published in JAGS in 2018. JAGS is the Journal of the American Geriatric Society. And it's called Associations Between Polypharmacy and Cognitive and Physical Capability, a British Birth Cohort Study. So, just to recap, yeah.
I like this already.
Tali's making a face, and it's good.
I am making a face because I work in a hospital. Just the amount of medication that older adults get surprises me every time.
It just depresses me now. I just expect it, and I'm saddened by it.
Oh, I know people that can prescribe antidepressant for that.
Oh, good.
Instead
More
of fixing
medication.
the problem.
Yeah, right. Exactly. So the previous Polypharmacy episode, which was published on January 15th of this year, it was a systematic review about general health outcomes, whereas this study is a cohort study looking specifically at cognitive and physical capability. So I thought it would be worth talking about.
Yeah, it's worth listening to.
Sweet. All right, so the authors are Mark James Rawle. He is a geriatric physician and clinical training fellow at University College London, who, according to his Twitter account, used to do improv.
Where? Now
in London.
Now I'm being an improv snob.
I saw it.
Collabs? Because
whoa. I saw that on his Twitter account and I was like, Tali's gonna love this.
Yeah, I have the philosophy that everybody should do improv.
Tali is excellent at improv. If you ever are out in New York City and at the People's Improv Theater, she's sometimes there.
I am sometimes there.
So after I found his Twitter profile, I was like, nothing can compare to this. So I just hear the rest of the people.
I don't know. You said that nothing can compare to it.
Well, nothing can compare to finding out that this geriatrician and clinical training fellow is also a guy who does improv.
It is. All right. So who's the next author?
Rachel Cooper. These are all PhD folks. Rachel Cooper, Diana Kuh, and Marcus Richards. And they're all PhDs.
And they don't do improv.
I didn't care to look. Because I was like, nothing will be as good.
Maybe they all do improv. Maybe that's how they met. Maybe they met in an improv class instead of a lab. Don't ruin this for me. This is what happened. Don't ruin it.
You know what? Let's just pretend that that's what I found.
Thank you.
So the improv troupe and researchers. So we're going to start with the introduction. In the United Kingdom, more than 20% of adults are prescribed 5 or more medications. The risk of polypharmacy is high in 3 different categories of people: older adults, those who are less educated, and those with higher disease burden.
Did they also say what is the risk in people that are all of the above?
You know, this is just the introduction, so they're pulling this from source material. So I bet in that source material it would have those answers, but I did not look.
You did not have to.
All right. Polypharmacy and worse lower limb function have been noted in observational cohort studies and lower mini mental state examination scores in a prospective cohort study of adults 75 and older taking 10 or more medications. This is the background. This is what we already know about polypharmacy, cognitive status, and physical performance. They're in general, it's worse.
Yeah.
For adults over 75 taking 10 or more medications. So as far as medication cessation is concerned, no effect has been demonstrated so far on clinical measures of cognitive or physical function, maybe because the measures examined were more general, like the number of falls versus changes in physical or cognitive capability, or that the prolonged polypharmacy may have a stronger influence than we thought. So this is them being here's what we don't know, and this is what we're going to address. So this paper, and this is a quote, examined associations between polypharmacy and detailed measures of physical and cognitive capability in a population representative age homogeneous birth cohort, adjusting for disease burden. We hypothesized that higher levels of polypharmacy would be associated with poorer cognitive and physical capability, and that these associations would be more pronounced with longer exposure to polypharmacy. That's pretty much it for the introduction. It's short and sweet, right to the point.
Yeah, good one. That's what introductions should do.
Yeah?
Introduce the subject.
Look at that. So this population, I think this is the most interesting part of the whole paper. The population is called the Medical Research Council National Survey of Health and Development Birth Cohort. This is a group of over 5,000 people, 47.5% female, who were born in England, Scotland, or Wales during a single week of March of 1946, who have been followed their entire lives.
Oh my god.
Right?
And the only thing that I can ask is why not Ireland also?
That's a good question.
Probably there was still like a war between the Protestant and the Catholics.
You're right, because, well, I don't know when that was happening, but again, this was 1946.
Yeah, it's not a good time.
I might need
Ireland
to,
is like, it's not a good time for us. Can you
the
come
NHS
back?
is like,
Can you come back later?
Yes.
Wow, this is awesome.
Right?
There are all like 5,000 people that were born in the same week.
Yep. Born in a single week in March of 1946.
How was that like decided?
You know what? It's something that I want to read a little more about.
Okay, sorry for asking a lot of questions.
You're allowed to. It's very interesting. So the data was collected when they were aged 68 to 69 with postal questionnaires and later home visits. 2,149 people had the home visits. And yes.
Sorry, in my mind. The way that they collected people to this study, they went to random places with like cupcakes or cakes and like happy birthday, and people were like, oh yeah, thank you. Oh, you were born today. Okay, we're like this is how they recruited people.
I think they probably did it a lot earlier, like in the hospital during that week. They went up to expectant parents and were like, hey, do you want your child to change the face of medicine? Blah, blah, blah. And they were like, why, yes. Yes, I do.
Well, yes. Yes, I do.
Good. All right. We both have our British accents. Okay. So for cognitive capability outcomes, all of these tests were conducted by trained research nurses. And what they looked at were verbal memory and processing speed. And they described the task, but there's no name for it. So we don't actually have any idea of its validity or reliability. But it was a 3-trial, 15-item word learning task with 2 word lists to minimize practice effects. Next is the Addenbrooke's Cognitive Examination 3rd edition, or ACE-3. It detects risk of Alzheimer's disease and cognitive impairment. So that's it, just 2 things for cognitive capability outcomes.
Okay.
Second were physical capability outcomes, and these were conducted by the same research nurses. They looked at chair rise speed and measured it as number of stands per minute. Usual walking speed from standing, and then it was over 2.44 meters. Then standing balance via a single leg stance test with eyes closed, and grip strength. And if they were unable to complete the tests, they were assigned a score equal to the mean of the sex-specific lowest fifth for each measure, which is apparently something that they've done with this cohort and other studies, and apparently it works fine.
Apparently it's fine. Don't worry about it.
It's fine. Don't worry. And they said, like, we did this before. They probably explained why they chose those methods in that other paper as well. Yeah. So then they also looked at polypharmacy.
What is their definition of polypharmacy?
I'm glad you asked. So they looked at regularly prescribed medications, and they compared the previous data collections at age 60 and 64, and they defined polypharmacy as taking 5 to 8 medications, and excessive polypharmacy as taking over 9 medications. And what they did, this is also something that's really cool about this study, is that looking at the data from age 60, 64, and then 68 to 69, they looked at polypharmacy over a period of time, which is something that hasn't really been done before.
Cool.
Yeah.
It's like, how many pills do you take now? And now? And now? And now?
Exactly. And they also did all these physical tests and cognitive tests at 60 and 64 as well. So this has been going for quite some time. Their entire lives, pray tell. So then they looked at the covariables that could influence the risk of polypharmacy, which were, as we stated earlier, sex, education, and they defined education as the highest education qualifications achieved by age 26, which, like, I got my doctorate at 29.
Yeah.
Right? That could have something to do with the education system in the UK, honestly.
Maybe it probably does, but it's weird. I know a lot of people that are doing their doctorates very late, or doing their masters very late, or or even their college degree.
You know, maybe in this cohort of people, like, people tended to not get higher degrees later in life.
I want to say that they're ageist, but
maybe,
but they're not.
Who knows? They also looked at disease burden, which they defined as number of self-reported doctor-diagnosed chronic diseases or disorders over the last 10 years, and they also included disease severity. So then the things influencing physical capability, they looked at BMI and standing height, and then they also looked at equivalent measures of cognitive and physical capability at ages 60 and 64. So they were used as a baseline. All of them except for the ACE-3 test were included back then.
Okay.
So then they use, for statistics, they use linear regression models were used to determine the association between polypharmacy and cognitive and physical capability. And they use this to adjust for those previously listed covariables so they could see the things that we know are probably going to influence with and without. All right. So that's it for the methods. You ready for the results?
Yes, please.
All right. They had over 80% complete data for all variables and covariables, and the total cohort number of participants was 2,007. So, like, there were a bunch that died, that decided not to be in the study anymore, that didn't complete the different testing.
Yeah.
Yeah, it's all listed there, but the total number is over 2,000 people.
That's big.
Yeah, so 18.2% of these people had polypharmacy at age 69, and that was all associated with poor cognitive and physical capabilities on all measures before and after covariable adjustment. So basically, yes, polypharmacy, people who had polypharmacy were worse off cognitively and physically than people without polypharmacy.
Yeah, but we don't know what the cause and the effects.
Right, but they took those different covariables into account, like education and blah 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 blah, disease burden.
Yeah, but are they getting medicine because, like people with Parkinson's usually have also some cognitive deficits?
Yeah, and that's where, like, it's a cohort study and it's observational.
I like observationals.
Yeah, we can't know causative.
We need to be aware.
That's a very good point.
That relation does not necessarily mean causality.
Yeah, that is a very good point. Thank you for noting that.
No problem.
4.7% of these people had excessive polypharmacy, which was more strongly associated with poor performance on all measures than polypharmacy alone. So the largest effect sizes for the ACE-3 score and the chair rise speed, and there's a figure with standardized comparisons. Okay, so then they analyzed the longitudinal associations. If people had both groups of ages with polypharmacy, they had lower mean cognitive and physical capability at age 69 than those without polypharmacy at any age except for grip strength. So, like, if they had polypharmacy at 60 and 64, then at 69, they were worse off. So people who exhibited polypharmacy at only one age had better scores than people with polypharmacy at both ages, and they scored worse than no polypharmacy at either age. So it's kind of like what we would expect.
The longer you have polypharmacy, the worse you'll get.
Yeah, this demonstrates that there could be an association with the length of time with polypharmacy. So then the people who had no medications had better cognitive and physical capability than those taking 1 to 4 medications, which were markedly better than those with polypharmacy. So it seems like there's this cumulative effect, or cumulative relationship, I should say.
But again, I do not want it to sound like we're saying that
drugs are bad and good.
Yeah. Because they are good sometimes.
All right, so that's pretty much it for the big results.
Man, thanks.
Well, there's a discussion.
Of course there is.
Of course there is.
Of course there is.
So these findings suggest dose-dependent cumulative negative associations between polypharmacy and cognitive and physical capability. So they talk about the strengths and limitations of this study. The strengths were that there was an age-homogeneous birth cohort with detailed health information and the ability to examine cumulative exposure due to the longitudinal nature of the study. And his limitations were sample attrition due to loss of follow-up, medication or disease burden relied on self-report data, but they accounted for all of this in their analysis. And they also said that one limitation is the definition of polypharmacy is really nebulous. So this is some evidence to suggest that there's some sort of cumulative exposure of polypharmacy over time, and they suggest that more research is needed. That's pretty much it for this article.
Yeah, that's a cool article. They didn't say what kind of medicine was.
No, it was only the raw number of medications.
Okay.
Yeah. Anyway, so this, like I said, was in Academy of Geriatric Physical Therapy newsletter that they send out in their email. Got it in April, and I'd start it, and I just now got to it.
Good job.
I've not been checking my emails regularly.
Yeah, same. The one I'm going to talk about next week.
Oh, yeah?
Has been in my email, I think, since we did the ageism.
Wow. That was like before CSM.
Yes, it was.
Cool. All right. Well, with that, thank you all for listening. We hope that you find the content that we talk about is helpful. We hope that you want to become our patrons on Patreon.
All right. Thank you very much, Erin. That was helpful.
No probs, Dr. Spaceman.
I'm Tally Spaceman.
I'm Erin Carey.
And this is SRP Rex. And as always,
stay funky.
Hit me. Thank you for listening to the Senior Rehab Podcast. If you only listen to these podcast episodes, you are missing out on 90% of the Senior Rehab Project. Hop on over to seniorrehabproject.com where you can join the movement that's advancing care for older adults. You can join for free or become a part of the Game Changers where you can get some free gear and access to our monthly meetup. Just go to seniorrehabproject.com. I appreciate y'all, and I'll talk with you soon. But in the meantime, do not forget to stay funky.